The next topic is nephrotic syndrome. This is a syndrome characterized by nephrotic range of proteinuria, which is defined as more than 3.5 grams per 24 hours. Patients also have associated edema, hyperlipidemia, hypoalbuminemia, and seldom patients can also have lipiduria. The protein in the urine is measured by 24-hour sample, but urinary protein to creatinine ratio can also be used as a spot proteinuria assessment method. In addition to the classical syndrome, the patients can also have increased thrombotic events, increased risk of infections, protein malnutrition, vitamin D deficiency, and there can also be drug toxicities due to increased protein binding. Renal biopsy is required for diagnosis and for planning of the treatment. Let's now look at the causes of nephrotic syndrome. These can be divided into systemic diseases, infections, drugs, and cancers. Systemic diseases include diabetes, which is the most common nephrotic syndrome cause, systemic lupus erythematosus, amyloidosis. Infections include HIV associated nephropathy, malaria, bacterial endocarditis, shunt nephropathy, hepatitis B, syphilis, and hepatic schistosomiasis. Drugs include gold, penicillamine, probenecid, heroin, NSAIDs, palmidronate, and interferons. Cancers include multiple myeloma, light chain deposition disease, Hodgkin's lymphoma, leukemias, carcinoma of the breast, and GI system. The glomerular diseases of nephrotic syndrome can be of various forms. These include membranous nephropathy, minimal change disease, focal glomerulosclerosis, membranoproliferative glomerulonephritis, mesangiocapillary glomerulonephritis, immunotactoid, and fibrillary glomerulonephritis. Let's now look at each of these in detail. The first one is minimal change disease. This is the cause for about 10 to 15% of the idiopathic nephrotic syndrome in adults and contributes to 80 to 90% of nephrotic syndrome in children. Patient's blood pressure is usually normal. Glomerular filtration rate is either normal or slightly reduced. Urinary sediments are either benign or may show few red blood cells. Protein selectivity is variable in adults. Patients can have recent history of upper respiratory tract infections, even allergies, or they can have recent history of immunizations. Even NSAID use can also lead to minimal change disease. Renal biopsy on microscopy is normal, but on electron microscopy there will be classical podocyte fusion, or also called as fusion of foot processes. Patients are usually treated with steroids and has good recovery rate. In certain patients who have relapse, they can be treated with either rituximab or calcineurin inhibitors. In children who are steroid resistant, there may be an underlying genetic cause. Progression to CKD or end stage renal disease is quite rare in this condition. The next subtype is membranous glomerulonephritis causing nephrotic syndrome. This accounts for up to 30% of cases in adults. Abnormal urinary sediments, hypertension, and even mild renal insufficiency develop later in the disease, not at the time of presentation. In diagnosis, an underlying systemic disease such as SLE must be evaluated. There can even be hepatitis B or solid tumors, or even exposure to medications like captopril, which can cause membranous glomerulonephritis. Renal biopsy can show subepithelial IgG deposition. Patients with idiopathic membranous glomerulonephritis causing nephrotic syndrome can have antibodies to the M-type phospholipase A2, which is expressed by podocytes. This antibody is written as anti-PLA2R antibody. Patients who are negative for anti-PLA2R antibody can be positive for anti-thrombospondin type 1 domain containing 7A protein, written as anti-THSD7A antibody in short. Around 20 to 30% of the patients undergo spontaneous remission. A small proportion go into CKD. The risk factors for progression include male gender, patients who are hypertensive, proteinuria of more than 6 grams per day, and older age. Treatment with just glucocorticoids is controversial. Promising results are seen with cytotoxic therapies and even cyclosporin. Rituximab can be used whenever there is anti-podocyte antibody that is present. Proteinuria is treated with ACEs or ARBs. Patients are at a higher risk for venous thromboembolisms. There is a 7% risk of venous thromboembolisms in these patients. Hypoalbuminemia of less than 2 gram per deciliter is a very good predictor of such events, and patients may require anticoagulation if venous thromboembolism is present or if they are at risk for venous thromboembolisms. The next topic is focal glomerulosclerosis. The presentation is very similar to minimal change disease, except the patients may have hematuria and may show evidence of renal insufficiency. This can be either primary or secondary, that is secondary to a particular cause. Primary disease is more acute and closely resembles minimal change disease. Renal biopsy usually reveals a juxtamedullary glomerular fibrosis. There is another pathologic variant called collapsing nephropathy. This closely resembles HIV-associated nephropathy, and they carry a rapidly progressive disease. A particular type of African variant of APOL1 gene, which codes for apolipoprotein L1, which is seen in podocytes, carries a higher risk for progression. Primary focal glomerulosclerosis is treated with extended steroid therapy. Cyclosporin is another alternative. Around 50% of the patients show remission, whereas the other 50 progress. An important thing to note is that primary focal glomerulosclerosis can recur even after transplantation, which leads to allograft rejection. Proteinuria is treated with ACE inhibitors or angiotensin receptor blockers. Secondary focal glomerulosclerosis can occur with any form of nephron loss, but it occurs usually in late stages. These conditions can include sickle cell, severe pyelonephritis, remote glomerulonephritis, or even vesico-ureteric reflux. In these patients, there is no benefit of glucocorticoids or other immunosuppression, and they will require adequate control of hypertension, and proteinuria is managed by ACE inhibitors or angiotensin receptor blockers. The next topic is membranoproliferative glomerulonephritis. Here the mesangial proliferation and expansion extend into the capillary loop. There are two ultrastructural variants of MPGN. These include MPGN1 and MPGN2. MPGN1 has subendothelial electron dense deposits. There can be C3 deposition in granular pattern, which indicates immune complex pathogenesis. In MPGN2, the lamina densa of glomerular basement membrane and even Bowman's capsule and tubules show a electron dense character. Small amounts of immunoglobulins, usually IgM, can also be present, but complements are absent. This condition is usually seen in young adults, and symptoms classically include hypertension, hematuria in patients who present as acute nephritis. There can be decline in glomerular filtration rate and even active urine sediments on labs. Treatment with glucocorticoids or cytotoxic therapy is of limited value. Rituximab can be used, and it has shown promising results. In patients with HCV associated cryoglobulinemia causing MPGN, patients can be treated with rituximab, and once the disease is under control, patient can be subjected to antiviral therapy directed against HCV, a rare subtype of MPGN with a pathologic process of alternative complement pathway activation, can be treated with eculizumab, which is an antibody against anti-C5a or complement 5a. The next cause is diabetic nephropathy. This is the most common cause of nephrotic syndrome. In type 1 diabetes, proteinuria develops in 10 to 15 years, which progresses to nephrotic syndrome, and end stage renal disease develops in the next 3 to 5 years. Patients with diabetic nephropathy almost always have diabetic retinopathy. This statement holds true in type 1 diabetes, so much so that if diabetic retinopathy is absent, then other causes for nephrotic syndrome should be evaluated. Whereas in type 2 diabetes, approximately 60% of the patients have diabetic retinopathy, whereas the remaining 40% of the patients may not have the features of diabetic retinopathy. Clinical features include proteinuria, hypertension, and decline in glomerular filtration rate. Pathological features include mesangial sclerosis, diffuse glomerulosclerosis, and nodular glomerulosclerosis. The nodular glomerulosclerosis is also called as Kimmel-Steele Wilson glomerulosclerosis. Most of the patients do not undergo renal biopsy with a history of diabetes that is prolonged and an added feature of albumin excretion in the urine usually gives a diagnosis of diabetic nephropathy. Yearly albuminuria evaluation is required to demonstrate progression in diabetic nephropathy. Typically, the patients progress from microalbuminuria, which is 30 to 300 milligrams of albumin per day, to being urine dipstick positive albuminuria, that is more than 300 milligrams of albumin in the urine per day. This further progresses to overt proteinuria and even chronic kidney disease. An important thing to note is that there is no clear correlation between the proteinuria levels and severity of kidney disease, which means that even a patient with mildly reduced glomerular filtration rate can have proteinuria as much as 25 grams of protein in the urine per day, and even patients with end stage renal disease or severe renal dysfunction may have very minimal proteinuria. The treatment of proteinuria focuses mainly on the following. The first one is a good glycemic control. The second is angiotensin converting enzyme inhibitors or angiotensin receptor blockers. Third is SGLT2 inhibitors. Angiotensin converting enzyme inhibitors are the best choice of medicine for control of proteinuria. But if the patient develops chronic cough, then angiotensin receptor blocker is a suitable alternative. The other adverse effects of angiotensin receptor blockers or angiotensin converting enzyme inhibitors include hyperkalemia. Patients can develop hypotension, and there can be worsening glomerular filtration rate, and also worsening kidney function. In such patients, loop diuretics can be used, and even potassium binders can be used to reduce the risk of hyperkalemia, and these include patiromer and sodium zirconium cryosilicate. As an overview of evaluation of nephrotic syndrome, the patients need to undergo urine protein creatinine ratio. This is a spot method to look for proteinuria level. The alternative is 24-hour collection of urine. Patients also need to undergo serum albumin, cholesterol levels, and even complement level assays. Urine can be subjected to protein electrophoresis, anti-nuclear antibodies, even evaluation for diabetes, a thorough history of exposure to medications, including alternative medicines, and if needed, patient needs to undergo renal biopsy to get to a pathologic diagnosis. The next topic is asymptomatic urinary abnormalities. These are the conditions where there is proteinuria that is in non-nephrotic range. Patients can have hematuria, but this is not associated with edema or worsening glomerular filtration rate or hypertension. The causes of asymptomatic urinary abnormalities can be broadly divided into isolated proteinuria in non-nephrotic range and patients with hematuria with or without proteinuria. These isolated proteinurias are further divided into primary glomerular diseases and secondary to systemic diseases. The primary glomerular diseases include orthostatic proteinuria, focal segmental glomerulosclerosis, and membranous glomerulonephritis. The diseases that are secondary to systemic diseases include diabetes, amyloidosis, and nail patella syndrome. The hematuria with or without proteinuria is again further divided into primary glomerular diseases, diseases that are secondary to systemic illnesses, and the diseases that are associated with infections. Primary glomerular diseases include Buerger's disease, that is IgA nephropathy, mesangiocapillary glomerulonephritis, and other primary glomerular hematurias. Primary glomerulosclerosis also includes thin basement membrane disease. Secondary to systemic illnesses include Alport's disease and other benign familial hematurias, Fabry's disease, and even sickle cell disease. The ones that are associated with infections include resolving post-streptococcal glomerulonephritis and resolving other post-infectious glomerulonephritis. Let's look at the first important cause of asymptomatic urinary abnormalities, that is thin basement membrane disease or thin basement membrane nephropathy. This is also known as benign familial hematuria, and this can be a cause for up to 25% of isolated hematuria that is sustained in the absence of proteinuria. Renal biopsy shows diffuse thinning of glomerular basement membrane, It may be a hereditary disease or defects in type 4 collagen. The disease is considered to be relatively benign. The next important cause is IgA nephropathy. This is a very common cause of recurrent hematuria, and here the hematuria is of glomerular origin. Patients present with episodes of macroscopic hematuria with flu-like symptoms. The renal biopsy shows diffuse mesangial IgA deposits, and hence the name IgA nephropathy. There will be small amounts of IgG deposits as well. There can also be C3 and propyridine deposition. The prognosis is variable, with approximately 50% of the patients developing end-stage renal disease within 25 years. The risk factors for progression include male sex, hypertension, and heavy proteinuria. Usage of glucocorticoids and immunosuppressive therapy is not routinely recommended, whereas the biopsy showing rapidly progressive glomerulonephritis or proliferative nephropathy can be treated with glucocorticoids plus immunosuppression. The next big topic is renal tubular disease. These include a diverse group of acute and chronic, hereditary and acquired disorders of renal tubules and supporting structures, and they are usually grouped as tubulo-interstitial diseases. In contrast to glomerular diseases, tubulo-interstitial disease do not have severe hematuria or proteinurias, but there may be azotemia owing to the associated glomerular fibrosis or ischemia. These patients instead present with a wide range of phenotypes, including hypo or hyperkalemia, metabolic acidosis, nephrogenic diabetes insipidus with polyuria, and even salt wasting. Before we look at the causes of tubulointerstitial diseases, let's look at various findings that are seen in tubulointerstitial diseases and the pathophysiology behind each of these findings. The first finding is reduced glomerular filtration rate, which is caused by obliteration of microvasculature and obstruction of tubules. The second condition is Fanconi's syndrome, which is caused by damage to proximal tubular reabsorption of solutes, and this is characterized by hypouricemia, low molecular weight proteinuria, and proximal tubular acidosis. The third finding is hyperchloremic acidosis, which occurs due to reduced ammonia production as seen in CKD and reduced excretion of ammonia as seen in hyperkalemia. It can also happen due to distal renal tubular acidosis, which reduces the capability of kidney to acidify urine. There can be proximal tubular acidosis, where there will be bicarbonate wasting. The next finding is polyuria associated with isostenuria. This can occur due to damage to medullary tubes, including collecting tubes and vasculature surrounding it. There can be hypokalemic alkalosis, where there can be dysfunction of distal convoluted tubule or ascending loop of Henle, as seen in Barter's Gitelman's syndrome. There can be hyperkalemia secondary to aldosterone resistance or potassium secretory defects, or there can be salt wasting, which can happen due to distal tubular defects with impaired sodium absorption. Now let's look at various causes of tubulointerstitial diseases of kidney. They can be broadly categorized into toxins, neoplasias, immune disorders, vascular disorders, and hereditary renal diseases. Toxins are further divided into exogenous toxins and metabolic toxins. Under exogenous, there is analgesic nephropathy, lead nephropathy, Chinese herb leading to nephropathy. There is Balkan endemic nephropathy, and other medications including antibiotics, radio contrast, heavy metals, and even cyclosporin. The metabolic toxins include acute elevations in uric acid causing acute uric acid nephropathy, hypercalcemia induced nephropathy, hypokalemic, hyperoxaluric, cystinosis, and Fabry's disease. Neoplasias include lymphoma, leukemias, and even multiple myeloma. Immune disorders can be acute interstitial nephritis, Sjogren's, amyloidosis, transplant rejection, and even HIV associated nephropathy. Vascular include arteriolar nephrosclerosis, atherosclerotic disease, acute tubular necrosis, and even sickle cell disease. Hereditary renal diseases include disorders associated with renal failure. These include autosomal dominant polycystic kidney disease, autosomal recessive polycystic kidney disease, medullary cystic kidney disease, and even Alport's syndrome, which is a hereditary nephritis. The hereditary tubular diseases can also cause tubulointerstitial diseases, and these include Barter's syndrome, Gitelman's syndrome, pseudo hypoaldosteronism types 1 and 2, Liddle's syndrome, characterized by hypertension and hypokalemia, hereditary hypomagnesemia, and even hereditary nephrogenic diabetes insipidus, which can be X-linked or autosomal. X-linked is associated with AVP receptor dysfunction, whereas autosomal is associated with aquaporin 2 dysfunction. The other causes include infectious, which can be either acute or chronic pyelonephritis, and there can be miscellaneous causes including vesico-ureteric reflux, chronic urinary tract obstruction, or even radiation nephritis. The first topic in tubulointerstitial diseases is acute interstitial nephritis. Drugs are the most important and most common cause for acute interstitial nephritis. Classically, these patients present with a gradual rise in serum creatinine over several days after initiation of a new drug. Patients can also experience fever, eosinophilia, there can be rashes, and even arthralgias. In patients who are previously exposed to the medicines, there can be a rapid decline in glomerular filtration rate, which is evidenced by increase in serum creatinine that is very rapid. One classical example for a drug-induced acute interstitial nephritis is rifampin, which if given in interrupted or intermittent dosing, then patients can develop acute interstitial nephritis. Apart from azotemia, there can be features that indicate tubular dysfunction, and these include hyperkalemia and even metabolic acidosis. Urine analysis may show hematuria, there can even be pyuria, there can be white blood cell casts, even eosinophiluria, which is seen on Hansel's or Wright's staining. Eosinophiluria is not a diagnostic test for acute interstitial nephritis, as it can be seen in other conditions also, other conditions causing kidney diseases also. Now let's look at the causes of acute interstitial nephritis. These include drugs such as antibiotics including nafacillin, oxacillin, methicillin, penicillins, and cephalosporins, ciprofloxacin, rifampin, sulfamethoxazole, and other sulfonamides. Proton pump inhibitors such as omeprazole, H2 blockers such as cimetidine, allopurinol, 5-amino salicylates, NSAIDs, and even COX-2 inhibitors, immune checkpoint inhibitors such as nivolumab. Infections that cause acute interstitial nephritis include leptospirosis, tuberculosis, Legionella, and even streptococcal infections. Other causes include tubulointerstitial nephritis with uveitis syndrome, written as TINU in short. Then there are idiopathic causes, sarcoidosis, and even rarely IgG4 related systemic disease. Drugs account for up to 70% of the cases. Infections cause around 16% of the cases. TINU accounts for up to 5% of the cases. Idiopathic cases are approximately 8%, sarcoidosis contributes to 1% of the cases, and IgG4 related is quite rare. Some important points regarding drug-induced acute interstitial nephritis. NSAIDs, apart from causing acute interstitial nephritis, can also affect the glomerulus. So they can have glomerular lesions which resemble minimal change disease, and these patients can have nephrotic range proteinuria. The renal dysfunction associated with drugs improve or show recovery after stopping the medications. However, these patients may not show complete recovery. Glucocorticoids have shown to be beneficial in cases that respond poorly to drug withdrawal. So glucocorticoids are mainly used in such patients to reduce or avoid dialysis. The tubulointerstitial nephritis with uveitis syndrome or Tino syndrome presents not only with uveitis and features of tubulointerstitial diseases, they also have arthralgias. They will have fever. On labs, they can have increased erythrocyte sedimentation rate. These cases are usually self-limiting, and if there is relapse or prolonged duration of illness, then patients are treated with prednisolone. The next topic is chronic interstitial nephritis, analgesic nephropathy, which results from cumulative exposure to drugs including phenacetin and even high dose aspirin and other NSAIDs, is the most common cause for chronic interstitial nephritis, and it is associated with chronic kidney disease and even progression to end stage renal disease. The manifestations include papillary necrosis, sterile pyuria, azotemia, and even renal calculi. The disease is suspected in patients with chronic back pain or joint pains or headaches with an underlying chronic kidney disease, which suggests a chronic analgesic use. A chronic form of tubulointerstitial fibrosis is associated with treatment with Chinese medicine. A similar form of tubulointerstitial disease is seen in Balkan endemic nephropathy, that is geographically restricted to people living in a part of southeastern Europe. Balkan endemic nephropathy is thought to be caused by exposure to aristocolic acid or other plants which are endemic to the Balkan region. The Chinese medicine, on the other hand, are used in dieting regimens, and the toxins implicated in development of chronic interstitial nephritis include appetite suppressants such as fenfluramine and diethyl propion. An important thing to note is that both analgesic and Chinese medicine induced chronic interstitial nephritis is associated with transitional cell carcinoma of urinary bladder and other genitourinary malignancy. Chronic therapy with lithium is also associated with development of chronic interstitial nephritis. However, this also has an important feature, that is nephrogenic diabetes insipidus, which classically stays even after withdrawal of lithium. As a general rule, the patients on lithium should be closely monitored for serum lithium levels and the glomerular filtration rate. If there is a decline in glomerular filtration rate, or if the patient is developing chronic kidney disease, then patient should be transitioned to alternate drugs to avoid progression. Co-treatment of these patients with amiloride may prevent nephrogenic diabetes insipidus in these patients. This works by blocking the entry of lithium into principal cells by amiloride sensitive sodium channels. Metabolic causes of chronic interstitial nephritis include hypercalcemia with nephrocalcinosis, oxalosis, hyperuricemia, hypokalemia, and even hyperuricosuria. The renal pathologic changes associated with hypokalemia include specific proximal tubule vacuolization, interstitial nephritis, and renal cysts. Other causes of chronic interstitial nephritis include sarcoidosis, Sjogren syndrome, radiation exposure in radiation therapy, and chemotherapeutic agents including ifosfamide and cisplatin. The next topic in tubulointerstitial diseases is monoclonal immunoglobulins in renal disease. These diseases have a wide variety of clinical manifestations, and the clinical phenotypes depend on the physiochemical characteristics of monoclonal immunoglobulins. The most common form is cast nephropathy, that is seen in multiple myeloma. Let's now look at the disease or the physiochemical aspect and the manifestations in each of these conditions. The first one is cast nephropathy. It is the most common form of monoclonal immunoglobulin related renal disease. It causes tubular obstruction with light chains of immunoglobulins. It is also associated with interstitial inflammation on biopsy, and patients can present with AKI or even chronic kidney disease. The next is light chain deposition disease. This presents as nephrotic syndrome and even chronic kidney disease, and approximately 40% of the patients with light chain deposition disease have myeloma. Monoclonal immunoglobulin deposition disease can present as nephrotic syndrome and even chronic kidney disease. Heavy chain deposition can present as again nephrotic syndrome and chronic kidney disease. AL amyloidosis can present as nephrotic syndrome with cardiac or neurological or even endocrine involvement, and approximately 10% of the patients are associated with myeloma. They also have evidence of renal tubular dysfunction such as renal tubular acidosis or nephrogenic diabetes insipidus. Now, the other conditions that can complicate kidney disease include hypercalcemia which is present in myeloma patients. Hyperviscosity syndrome, commonly seen in Waldenstrom, macroglobulinemia. Fanconi's syndrome, associated with glycosuria, amino acid excretion within the urine. Phosphaturia, with or without hypouricemia, and even proximal renal tubular acidosis. Let's now look in detail about caste nephropathy. It is the most common monoclonal immunoglobulin related tubular disease of the kidney. It is associated with multiple myeloma, where the filtered light chain cause aggregation leading to tubular obstruction, inflammation, and renal injury. These patients can present as AKI or even chronic kidney disease, and the risk factors include hypercalcemia and volume depletion. Diagnosis of caste nephropathy is by detection of monoclonal immunoglobulin light chains in serum or urine. The methods that are commonly used include serum electrophoresis and immunofixation assays. An important thing to note is that urine dipstick method will not detect light chains, because urine dipstick methods usually detects only albumin, and as there is no albumin in the urine, the albuminuria is negative, so dipstick can become negative. Whereas in light chain deposition disease, the deposition of light chain happens within the glomerulus, leading to glomerular damage and hence causing protein leaks where albuminuria is present, and these patients have a urine dipstick positive as they are detecting albuminuria. Even AL amyloidosis can also present similarly with a urine dipstick positive for albumin. The management of caste nephropathy includes hydration, hypercalcemia measures, treating the underlying multiple myeloma, and in cases with severe acute kidney injury and very high levels of light chains, patients can be subjected to plasmapheresis. The light chains that are filtered are usually endocytosed and metabolized by proximal tubular cells, but rarely some light chains can cause crystalline depositions in the proximal tubules. This may result in Fanconi's syndrome and even dysfunction of distal nephron, leading to hyperkalemic acidosis or even nephrogenic diabetes insipidus. This condition is also seen with renal amyloidosis. The next topic is polycystic kidney disease. It is the most common life-threatening monogenic genetic disorders of kidney. There is an autosomal dominant form called ADPKD and a autosomal recessive form, that is ARPKD. Autosomal recessive generally presents in infancy and childhood. Hepatic involvement in the form of hepatic fibrosis and hepatic cysts are common. ADPKD presents in adults. The gene involved is PKD1 or PKD2 gene. The renal cysts in ADPKD are large in size, and these patients can progress into chronic kidney disease and end-stage renal failure. In ADPKD, apart from the renal cysts, patient can also have hepatic cysts and intracranial aneurysms. Any patient with family history of ADPKD along with aneurysmal rupture should undergo screening for aneurysms. Clinical features include a palpable kidney. Patients can also have diverticulosis and even mitral valve prolapse. Typical presentation is recurrent hematuria, that is gross hematuria. Patients have hypertension. Patients can also have CKD features. There may be episodic flank pains, and there can be recurrent urinary tract infections. The renal phenotype is more severe in PKD1 mutation than PKD2 mutation, and patients with PKD1 mutation can develop end-stage renal disease 15 years earlier compared to PKD2. A small subset of patients can have an incidental detection of cysts on ultrasonography. The diagnosis of polycystic kidney disease is made with ultrasonography. The criteria is characterized according to the age and the number of cysts. For people who are 15 to 29-year-old, 2 cysts, which can be either unilateral or bilateral within the kidneys, is diagnostic. Patients from the age 30 through 59 years should have 2 cysts in each kidney to be diagnosed as ADPKD. Patients above the age of 60 years should have 4 cysts in each kidney to be called PKD. Renal cysts might be seen even in normal individuals, especially in chronic kidney disease patients, and hence the criteria should be matched to diagnose polycystic kidney disease in the patients. These patients of polycystic kidney disease can have hypertension in the absence of decline in glomerular filtration rate, and the hypertension is mainly due to activation of renin-angiotensin aldosterone system, and hence these patients are treated with angiotensin converting enzyme inhibitors or angiotensin receptor blockers with a target blood pressure of less than 130 over 80 millimeters of mercury. Treatment under studies for autosomal dominant polycystic kidney disease in preventing progression to CKD are vasopressin antagonists, somatostatin analogs, and cell proliferation inhibitors. Patients with polycystic kidney disease can have recurrent urinary tract infections, and there can be infections localized to the cysts. These patients can present with a localized pain in the flank, and it can be sometimes misdiagnosed as pyelonephritis. The differentiation between pyelonephritis And cyst infections is important because the common antibiotics such as penicillins or aminoglycosides do not penetrate the cyst adequately, and hence these patients must be treated with fluoroquinolones initially, and it should be directed by cultures. The last topic in tubulointerstitial diseases is renal tubular acidosis. This is a common terminology used for different pathological entities whose common feature is non-anion gap metabolic acidosis. Diarrhea, chronic kidney disease, and renal tubular acidosis together constitute majority of non-anion gap metabolic acidosis. CKDs usually present initially as non-anion gap metabolic acidosis and later on progress to increase anion gap. In patients with CKD, where distal part of the nephron is affected, acidosis develops very fast and early. There are three important types of renal tubular acidosis. The first one is distal hypokalemic renal tubular acidosis, also called type 1 renal tubular acidosis, proximal renal tubular acidosis or type 2 renal tubular acidosis, and type 4 renal tubular acidosis. Distal hypokalemic renal tubular acidosis is where the patients are unable to acidify urine even in the presence of metabolic acidosis, and patients have a positive urinary anion gap which reflects a reduced ammonium excretion. The causes can be either inherited, usually in autosomal dominant or autosomal recessive forms, or it can be acquired due to autoimmune conditions such as Sjogren's or sarcoidosis. It can also be caused by urinary tract obstruction or amphotericin B therapy. In patients with chronic renal tubular acidosis of type 1, due to long-term buffering of acid by the bone, patients can have hypercalcemia and osteomalacia. In proximal or type 2 RTA, there is a defect in bicarbonate absorption which is associated with Fanconi's syndrome and constitutes glycosuria, amino aciduria, phosphaturia, and uricosuria. This denotes a proximal tubular dysfunction. Isolated proximal RTA can be caused by hereditary defect in basolateral sodium bicarbonate co-transporter. Fanconi syndrome can be inherited or acquired due to Chinese medicine, causing chronic interstitial nephritis, myeloma, or even drugs like ifosfamide or tenofovir. Treatment for type 2 renal tubular acidosis is high dose sodium bicarbonate therapy, but it may precipitate or worsen hypokalemia. Bicarbonate is given in the dose of 5 to 15 millimoles per kg per day. The type 4 RTA may be due to hyporeninemic hypoaldosteronism, or it can be due to resistance of distal nephron to aldosterone. Hyporeninemic hypoaldosteronism is associated with volume expansion, and it is commonly seen in patients who are elderly or in patients who are diabetic with chronic kidney disease. Hyperkalemia, that is associated with cyclosporin and even NSAIDs, is attributed to hyporeninemic hypoaldosteronism. These patients also have mild non-anion gap metabolic acidosis, and the urinary pH can be less than 5.5 with a positive urinary anion gap. Acidosis usually improves with reduction in serum potassium. This is because hyperkalemia interferes with medullary concentration of ammonium by affecting the counter current mechanism. These patients can be treated with oral bicarbonate or citrates. And resistance to distal nephron is seen in various patients with distal nephron injury, and here urinary pH will be more than 5.5. This completes the tubulointerstitial diseases. Thank you.